indicate orbit to orbit, and these are the structures we want to remove. The main thing is, if you see the blue line here, is as you do a draft 2B, you have to be cognizant where the anterior most portions of the cribriform plate is. Most of the olfactory fibers are going to posterior to that line. So if you stay anterior to that line, you're safe as far as olfaction. We do a superior anterior and septectomy of variable degrees so that we can work from either side simultaneously. Drill on one side, telescope on the other side, be able to use both sides to work. This is some of many studies showing the presence of olfactory fibers, and you see the concentration of olfactory fibers outside the cribriform is mainly high up in the vertical lamella of the superior middle turbinate, right here, posterior to that line where it's the back wall of the frontal. And on the septal side, again, it's high up in the first centimeter or so. And I have a partner that does stem cell research right now on olfaction, and we're doing a lot of re-injection for anosmia with stem cell at our Stem Cell Institute. And so we've learned a lot more about this. And olfactory cells are probably, the fibers of olfactory are probably the most highly regenerative and stimulable nerve fibers in the body. Just the mere presence of trauma can stimulate reproduction. This is the final Lothrop size, and this is something that you want to manage patient. And the interesting thing is we do these a lot for polyp patients, for people with a lot of osteogenesis. And the whole purpose is that it's for topical therapy. The real treatment is the topical therapy that happens afterwards. And in order to get the topical therapy into the frontal and henceforth the rest of the sinuses, we create these cavities because there are many companies that now make it for us, but we have many different irrigations and topicals with virtually any antibiotic and all those very strong steroids. And that's how we deliver it into these cavities to control it. So when you convert from a draft 2B to a draft 3, all you're doing is taking this inner sinus septum and part of the perpendicular plate. The asterisk is where the cribriform plate is. Once you know where that is, everything anterior to that is fair game. You just go for it and just remove it. And you'll practice that, hopefully, for those of you who want to do it in the lab. You drill it down, you see you start entering the right frontal, and you continue taking it off, and you actually can do a Lothrop from left to right without even touching the right side. You don't necessarily have to do an ethmoidectomy on the right to do it, although it's possible as well. And again, this is just a completed Lothrop looking from the right side, from the left side still, and you can see the right sinus, left sinus. And then if you go to the right side and look over the left side, one of the advantages of the Lothrop is that you can address pathology over the orbit. So you can go from right to left to get over the orbit to get the pathology up there, like inverted papillomas and certain tumors. This was the last study we did years ago, and it hasn't really changed. We know that about 94% of the patients remain patent. Of those, 33 are less than the original size, 50% less than the original size of the intraoperative opening, but still asymptomatic, and they do well. There is about a 10% incidence of reclosure completely. Most of those are asymptomatic. Some have to go back to either a redo Lothrop, or very rarely do we ever do an obliteration procedure. Special considerations when we do these procedures for extended, there are situations like this where we have a patient with recurring cellulitis, has a little defect in the bone, has an opacified, otherwise hypoplastic frontal, and there is probably an indication, as in this case, to do what we call a transeptal approach, where we go anterior to the normal recess and normal infundibulum. And what we do is we go, if you notice, you don't see middle turbinate on this coronal view. And what we're doing is we're going transeptally or a little laterally, what we call supraterminally, to enter one of the two frontals through this area, find the back wall of the frontal, and once we find the back wall of the frontal, we now just drill it and connect to both sides. So the arrow basically tells you the direction we're going. Notice that we're anterior to the anterior attachment of the middle turbinate. So that's a transeptal approach. And in some cases like this, there is an argument for obliteration, auto-obliteration, where we go in there, drill out not just the opening, but drill out all the mucosa endoscopically with the hope that it will contract, turn into scar and bone, and auto-obliterate like in the old days, except you don't stuff it with fat. And that's basically what we did in this case. The other thing on exam, notice this is the right side of the nose of this patient, this is the left side. When you see this type of pathology high up on the anterior ethmoids around the frontal, this is a clue that it's that the pathology is coming from the frontal sinus. Okay, and of course this is a type of. I'm just going to quickly just go through here. We have a few minutes, a couple minutes left, but basically you can see the CT scan. There's a lot of bone to be removed, and basically what we do is we drill that area out. We enter the cavity, and at the end we suction all that pus out of there. And we continue drilling, and we did this in the midline through a transeptal approach to really recreate the cavity and to get all the mucous membranes out all the way around, and we drill it all out. We palpate the nasion and the canthal area because those are our limits. It's okay to see dermis. In fact, we do it intentionally sometimes. We'll drill until we see the dermis of the nasion or the canthus, and then, of course, postoperatively, we want to have cavities that contract down and are manageable. We sometimes use rolled silastic. If we do a lot of drilling, we'll leave these in for a couple months. Sometimes we'll change them out. This doesn't really prevent the restenosis or change the restenosis or closure rate, but it does make it easier to manage the cavities with irrigations, and it doesn't hurt when you clean them up there because it's protected. It's lining the cavity. So sometimes we'll use reinforced silastic. Let's go on with this. There are indications like this where there's a patient, a typical patient who's had either a blowout or a fracture or some sort of medialization procedure where they continue having frontal procedures, and in that case you do a contralateral frontal and then you cross the midline through a Lothrop from right to left, sort of like I showed you previously. So this is one common indication where you might want to do a Lothrop to be able to address that frontal sinus. Other times there may be meningoceles, such as this. Let me go forward a little bit. And you remove the meningocele that happened to be in the, from the front. This one happened to have one in the sphenoid too. We find a defect, we do a Lothrop so we can work from both sides, control the cavity, and then we put our defect. A topic for another discussion. Other mucoceles, huge mucoceles, sometimes lend themselves for follow-up to do the Lothrop so you can follow them. And of course, pericranial abscess. When I was a resident, these Potts-Puffy tumors, we used to have to do obliteration. Nowadays, we just, when they do pop up, we do a Lothrop, widely open it, irrigate it, and make sure that these patients immediately get better with their problem. And of course, you got cavities that you can follow. And of course, the ultimate use of the Lothrop that you'll hear probably in the next speaker is going to be the use in skull-base resection. It's a vital component of an anterior skull-base resection to be able to get the anterior margins of resection along with an extended sphenoid back here and then orbit to orbit resecting the anterior skull-base. Thank you.
Good morning, everybody, and I would like to thank the organizing committee to let me present in this very nice sinus and anterior skull-based course. For all of you who don't know me, there's people from residents from Dama. I'm Talal Indijani, and I'm a rhinologist here in King Abdulaziz Medical City in Jeddah. So I'll be talking about anterior skull-based dissection. One of the nice things I was talking with Professor Kazian yesterday while we were coming back from dinner, and there's two schools in the States now. The school who were doing anterior skull base, but they're head and neck surgeons, and the school who were doing anterior skull base who are rhinologists. And there's a difference in the way how they take care of the sinuses. The head and neck surgeons, they just want to remove everything, and they don't really care that much about the physiology, about the sinuses, and about the nose. But us as rhinologists, we want to take care of the nose and physiology as much as possible, because that's probably our other, what we do in the clinic. We take care of the sinuses, and as how Professor Kaziani said, the medical treatment after surgery. It's not only skull base, it's also sinus diseases, sinus physiology, and function. So today I want to show you how to be a good rhinologist and a good anterior skull base surgeon. So my topic is going to be about three things: what, why, and how. So what is the anterior skull base? So the skull base actually, it's this part. It's a floor of the cranial cavity, and it separates the brain from the other facial structures. So if you make a line here, the brain is here, and everything else is over here. And Professor Ford is here. Sir Ahmed. And where's our neurosurgeon? The 50%, our partner. So our anterior skull base, okay. So if you can see this line here, okay, this is anterior planning process. This is the lateral sphenoid. So anything anterior to this, it's the anterior skull base, and this is what we'll be talking about. And they also divide into central and lateral. Okay, lateral mostly goes into the intertemporal fossa and palatine fossa. So why is it important? Well, we have all these structures in our anterior skull base. Olfactory nerve, cranial nerves, and internal carotid artery, brainstem, frontal lobe, and also the CSF, where you could have CSF leaks and sequelae from that as meningitis. So when I first started sinus surgery, and when we were doing sinus surgery, just as a rhinologist, they always told us stay in the box. Okay? And this is, I think our talk today in the basic course is mostly going to be about FEST. Tomorrow and after it's going to be about skull-based surgery. So today we're all going to concentrate how to stay in the box. Tomorrow is how we will go out of the box. Okay. So about anterior skull-based dissection, I think it's a very important to master this technique, and I think it's one of our workhorse areas in as sinus surgeons. And why is that? Because to do a good FES surgery, we need to really master this anterior skull-based dissection. In order to remove completely the disease, you don't want to leave any cells on the skull base. And the other thing is avoid complications. Once you know where your skull base is and where all the main structures are, you don't go into the brain, you don't injure any major vessels. About skull base, we'll talk about these tomorrow, but I just want to give you a quick view about the business. We're not going to be here tomorrow. This is the diseases we can treat, and this is the skull base. And these are the ways, or endoscopic approaches, how we can enter the skull base. So the dissection technique, what we usually use is the Maser-Kliner technique. Maser-Kliner, he's what we call the godfather for sinus surgery, and he's from Austria, and he invented this technique in the 60s and 70s. So when we do sinus surgery, we go through these lamella, and if you can see here, we go through the uncinate, bulla, middle turbinate, superior turbinate. Then when we get to the sphenoid recess, we will clean the skull base, or the anterior skull base. So what I want you to master in the cadaver dissection is this technique, going from posterior to anterior and medial to lateral. And why is that? This is the safest way to clean the skull base. And this is actually the way we don't have navigation system. It's going to help us also to get to the frontal recess and frontal sinus, and I'll show you how to do that. But why do we do posterior to anterior? Any of the residents know? So we're on skull base, and we always go posterior to anterior. It's not anterior to posterior.
The slope.
Yes, because of the slope. So you want to go. And why do we go medial to lateral?
Away towards the orbital.
Yeah, you want to go away from the LCP, as Professor Kaziani said, and you want to, which is the thinnest part in the skull base, and you want to go laterally because the orbit has a more thicker bone. So it's always posterior to anterior and medial to lateral. And if you see Professor Stamberger, he always uses a curette and cleans that area. So these are the steps. First of all, after we go here, okay, we have to identify the sphenoid sinus, sphenoid recess. Then we have to see if there are any unwanted cells. Then you always have to see your skull base, because most of the time it goes upwards, but there are times that it can go horizontal and it can go downwards, or it have a slope. And sometimes they can be defects, okay? Then you want to identify your posterior and anterior point arteries. You have to see your curious classification and frontal cells. So about the sphenoid sinus here, I'm not going to talk a lot about it. I think it was covered yesterday. But you have to know your sphenoid sinus, okay? Because you have to have a starting point. After you know your type of sphenoid cell, you have to see in the CT scan, is there an unwanted cell or there isn't? Because of two points. One thing is, if you are not in the unwanted cell, okay, you don't really know where your posterior part of the skull base is. And the other thing, if you are in your unwanted cell, okay, and you think, and you don't know it's an unwanted cell, and you think your sphenoid is still posterior to it, you might enter the optic nerve or sella or carotid artery, as you can see here. Okay, then you want to, after you see your after you identify your unwanted cells and sphenoid sinus, you want to see your sphenoid frontal recess, which is this part here, okay, and your CT scan. It's a space between the superior turbinate face of sphenoid and roof of nose. It's a posterior border, the anterior space of sphenoid, okay, and natural sphenoid ostium is it's a natural sphenoid ostium drainage pathway. There is no clear-cut anterior or inferior border. So after that, you want to identify your posterior ethmoid artery. Now, usually the posterior ethmoid artery is not like the anterior ethmoid artery. It's either absent, or it's most of the time it's embedded in the bone. 30% of the time you can see it, and less than that it has dehiscence. Now, this case I did a few months ago, and we could identify the posterior ethmoid artery. Usually it's about 5 to 6 millimeters in front of the sphenoid recess area. Now, it's really important to see if there's a dehiscence or there's a mesentery in the posterior and anterior ethmoid artery, because when you clean that area, and if there's a mesentery, you might make a tear, or you might cut through it and make an orbital hematoma. And this is our sphenoid ostium. The other thing is you have to know your Creos classification. So after you see your posterior ethmoid artery, you want to clean the skull base, but you can't actually clean your skull base without knowing this. And all the residents are telling me you have to see this. If you don't, if you can't classify your Creos classification before surgery, you don't get to operate. Because what happens if you get a type D or asymmetrical, okay, like this one, or type 3. I think this was discussed earlier yesterday, but I just want to go through it. Another thing is you always have to see your skull base, because what happens if you don't really recognize this and you're doing skull base? You'll get a CSF leak, you'll get brain herniation, and if you don't recognize that worse post-op, you'll get more complications. So you have to see your CT scan very well. After you finish cleaning your skull base, you get to your frontal recess area. Okay? And the most important area in the frontal recess area is your anterior ethmoid artery. 30% of the time it might be dehiscent, and about 5 to 10% of the time it might be in a mesentery, which means that instead of being here, it's over here. Okay. Now the frontal recess area, as I think they mentioned yesterday, we don't call it the nasofrontal duct anymore. It's an inverted funnel shape, and posteriorly it's bounded by the anterior skull base, and anteriorly by either nasi and the frontal or anterior buttress. Now, the next thing about the anterior ethmoid artery, I'll just talk about it a bit. Where can we find it? It's usually a few millimeters in front of the bulla lamella. So this is the ethmoid lamella, and it connects to the skull base. And right at the attachment or in front of it, over here, you'll find this anterior ethmoid artery. You have to know your frontal recess cells if you want to clean the skull base area, and I'll talk about it more. This is the anterior ethmoid artery. And this is a okay. This is a case I did a few months ago, and this is, you can see your anterior ethmoid artery. Now the next thing I want to show you about the anterior ethmoid artery is as soon as you identify your anterior ethmoid artery, the skull base goes upwards. So if you identify your anterior ethmoid artery, then you know you're safe anywhere in front of that. And that's really important if you have lots of frontal disease, if you don't have a navigation system, you can clean that area. Okay? This is again, I'm dissecting around the ethmoid artery and showing the rhythm. Any of the residents seen anterior ethmoid artery during surgery? Okay. Now in all my surgeries who have hand sinus disease, I clean the skull base like this. If there's a mesentery and dehiscence, I have to see the anterior ethmoid artery because I don't want to be picking any of the cells or the lamella without knowing where my ethmoid artery is. Now in this case, I cauterized the anterior ethmoid artery, and the reason I cauterized it is there was a lot of bleeding, and just for educational purposes, the resident with me never saw ethmoid artery cauterization. And the other thing, I never pack my noses or sinuses after surgery, so it's really nice to not have any bleeding after surgery. You can see the cauteries here. Sorry, actually our video, our camera and our tower is not working, so I have to use my iPhone to take pictures. So, but you can see the cauterization here. Now the skull base and frontal sinus, and this is what I want. This is another case of frontal sinusitis. Okay, and this is how you should be cleaning your skull base in the frontal recess area. You can see I'm picking the bones here. Okay, and this lamella, cleaning the skull base, cleaning the frontal recess area. And then after you clean that, my anterior ethmoid artery is here. This is all posterior frontal wall, and I'm going to put my debrider in here and just fix it anteriorly, and we clean everything here. This is, you can see fungal debris inside, and this is the debrider. You can see how once you know your anatomy, you're very safe, and you can do surgery confidently. This is an agonese. I saw that's the roof of it. The supraorbital ethmoid cell is removed, and this is the frontal recess area. And you can see how I'm cleaning on skull base here, okay, with my debrider looking anteriorly, and I'm not actually afraid of any complications. The other thing is, I'm sure, and I know my lamina papyracea is intact. Okay, and this is how your